Bismillahirrahmanirrahim. Assalamu alaikum everyone. Today we will be starting with a new topic which is of dental composites. However, before we actually start dental composites, it is important to understand a few principles which I will be talking about in this lecture, which are mainly adhesion and bonding. Because this tooth colored restorative material known as composite bonds to the tooth directly, it is important to understand this mechanism first. Now let's look at the learning outcomes. You should be able to understand the principle of adhesion and the factors associated with adhesion. Describe the concept of enamel and dentin bonding. Explain what is acid etching, its steps and application in different dental procedures. And finally, classify the different bonding agents with their limitations as well as benefits. So, adhesion and bonding. As you know, adhesion is basically defined as the phenomena that takes place when two substances are brought into intimate contact with each other and molecules of one substance adhere or attracted to the molecules of the other substance. So basically, this is the interaction between two materials at their interface or surface where they are in contact. So, with adhesion, you have an adhesive, the material or film producing an interface or causing adhesion, which can be said as the intermediate or the third material that joins both of the surfaces together. And then the adherent, which is the material or surface onto which the adhesive is applied or the initial substrate. As you can see from this picture, this is basically of a tooth and a restoration. And the third or the material in between is the luting agent, which is actually joining the tooth and the restoration to each other. So the luting agent is the adhesive, and the adherent are the tooth and the restoration. And these are basically attractive forces between the tooth and the luting agent or the adhesive, and the luting agent and the restoration, and they operate at interfaces of dissimilar surfaces, and these attractive forces are known as adhesion. Again, this is a picture of or representation of the two surfaces, the adherents with an adhesive molecule in between. Forces of cohesion also exist, which are basically between similar molecules or within a material, and then the adhesive forces. So, what is the importance of adhesion and bonding in dentistry? So, all the dental restorations require retention by some system of connection or attachment. Obviously, they have to be retained within the tooth, so they require some sort of mechanism. Application of adhesion and bonding in dentistry. Basically, adhesion is required in crowns, fixed partial dentures, veneers, and other prostheses that require a luting agent or a cementing agent that fills the minor irregularities along the prosthesis and tooth surface. So this is an example of a crown, and it is bonded or it adheres or bonds to the tooth by means of a luting agent or a cementation agent. Another classic example is of an impression. So, when you take an impression and you pour it with plaster or gypsum, so wetting of impression material with that gypsum is important, and that will only take place if there is good adhesion of the gypsum and the impression material. So, these are two examples of adhesion and bonding in dentistry. So, what are the ideal requirements? Well, first of all, it should be biocompatible. That means non-toxic and non-irritant. We're talking about the bonding agents. Low film thickness, low viscosity, so that it flows properly because we have to achieve good wetting in order to get good adhesion. Form a strong permanent bond. It should have good dimensional stability so that should not show any kind of change in its original dimensions. Similar coefficient of thermal expansion as tooth so that it contracts and expands with the tooth. Low thermal conductivity, good shelf life, and it should be able to prevent micro leakage. Now, what are the requirements to achieve optimal adhesion? Firstly, your surface should be very clean, and The bonding agent should have a low viscosity to flow easily. Adhesive should wet the substrate well and have a low contact angle and spread onto surface. I'm sure you all remember we talked about adhesion in the first chapter as well, and we discussed the contact angle, the wetting. So this is basically a repetition of the same concept. Intimate approximation at interface without entrapped air. This is very important that the approximation or the contact at the interface should be intimate and there shouldn't be any entrapped air. Interface includes sufficient physical, chemical, and mechanical strength. Again, an important point. An adhesive should be well cured and should harden on setting. So these are all the requirements to achieve the best possible adhesion. Now, what happens if contamination takes place? As you know, contamination is basically if moisture, saliva, blood, or any kind of fluid actually manages to get in contact with your material that you're placing in, and this has detrimental effects because it affects the setting and it affects the properties, overall properties of the material you're using, and in this case definitely it will affect the adhesion. So we try to achieve good moisture control and isolation so no kind of contamination is able to affect the adhesion. So an important thing is the smear layer. So a smear layer is basically a debris layer formed by preparing enamel and dentine with rotary instruments smeared onto their surface. Whenever we carry out a cavity preparation in the tooth or more than or teeth, what happens is that when we are cutting away enamel and dentine with our instruments, a debris layer forms which is composed of enamel chips and there may be some plaque and basically it's a debris layer. So that layer is called a smear layer. It is of a few micrometers thick and that can also be a cause of contamination. So we have to clean that smear layer, remove that smear layer, and then proceed with our bonding. So the smear layer is a very important layer, and it's often asked as well in the viva that what is a smear layer. So it is defined as any debris calcific in nature produced by reduction or instrumentation of enamel, of dentine or cementum. Like I said, whenever you are carrying out any procedure on the tooth about tooth cutting or cavity preparation, so the debris left behind by your instrumentation is the. Let's talk about the contact angle. So, if you can recall, it is to the extent to which an adhesive wets the surface of an adherent and determined by the contact angle between the adhesive and adherent. You can appreciate this is basically your adherent, and suppose this is the adhesive, the liquid. So, the angle that is formed between the both surfaces is called the contact angle. So, it is the angle formed at the interface of the adhesive and adherent. What is the importance? Complete wetting occurs at 0 degrees contact angle and no adhesion at 180 degrees. So that means ideally our contact angle should be low or 0, and if the contact angle increases, the wetting or the flow decreases. And the contact angle gives an indication of the wettability or spreadability or ability to flow. Smaller the contact angle, better the ability of liquid to flow into and fill the irregularities within the surface of the adherent. So that's the importance of the contact angle. Again, this is a diagram of the adherent and adhesive, and the angle that is forming between these two surfaces is the contact angle. In this case, it's a low value of contact angle. That's why the adhesive is spreading intimately and properly like we want it to over the adherent surface. Again, what is the importance? Bad wetting is indicated by a high contact angle. A good or a favorable satisfactory wetting is indicated by a lower than 90 degrees wetting, 90 degrees contact angle, for example 45 degrees. An excellent or complete wetting where there is intimate and proper flow of the adhesive is indicated by a 0 degrees contact angle. Now let's move on to the bonding agents, which basically are the topic of concern uh, in today's lecture. So we've talked about adhesion and bonding. Let's move on to the bonding agents. So bonding agents are basically uh, materials of low viscosity, and they are applied to tooth surface and form a thin layer after setting. So basically in the composite filling, in the steps of the composite filling, this is an important part where we apply bonding agents and then we apply the composite. Because the composite cannot bond by itself to the tooth, we have to apply an adhesive or bonding agents as they are known as, to the tooth first, and then only can we apply the composite. This thin film bonds to the tooth surface, and onto this composite restoration is applied. So this is basically the adhesive which will hold the composite resin and the tooth surface together. This is an important component of the composite restoration technique. So let's talk about the dentinal bonding agents. So they are designed to provide a sufficiently strong interface between the restorative composite and the tooth structures to withstand any mechanical forces and shrinkage stress. So the main purpose is to provide adhesion and a good interface between the composite and tooth structure. The success of adhesives is dependent on two types of bonding: micromechanical interlocking and chemical bonding with enamel and dentin or both. We will be looking into detail of both these mechanisms, and copolymerization with the resin matrix of composite materials. What are the components of bonding? We have etchants or conditioners, primers, and adhesives. So, an important terminology we will be discussing which involves bonding, especially in case of composites, is acid etching. So acid etching is basically a application of an acid to the dental surface to remove the smear layer, because as we discussed previously, the smear layer is a source of contamination and it interferes with the bonding or adhesion of the bonding agent onto the tooth, so we have to remove it. And opening the enamel tubules, what happens when we open up the enamel tubule? There is increased surface area and increased retention of the resin sealant and promotes mechanical retention. So acid etching, the main purpose of it is to basically remove the smear layer, increase the surface area, open up the enamel tubules to allow better wetting and better flow and better bonding of the composite filling. So what are the available etchants or conditioners? They are also known as enamel conditioners, but the more popular term is etchant. So there are organic acids like maleic acid, EDTA, citric acid, tartaric acid, polymeric acids like polyacrylic acids, and inorganic acids like phosphoric acid and nitric acid. Now, after the etchant, let's move on to the primers. So, primers are basically adhesion promoters, and they increase the wettability and penetration. So, they are basically facilitating the adhesion, and they are basically bifunctional molecules which have two ends, a hydrophilic end and a hydrophobic end. The hydrophilic end binds to dentin because, as you know, that dentin has a tubular nature and it has dentinal fluid, and the hydrophobic end binds to the composite resin because composite resin is hydrophobic and it alone cannot bond to the tooth. It needs some sort of intermediate molecule between it to help it bind to the tooth, which includes both enamel and dentin. So that is why we use primers. They facilitate the adhesion as they are bifunctional, and what they do is that they ultimately convert the hydrophobic composite to hydrophilic for improved bonding. Now let's move on to the third component, which is the adhesive resins. So they are basically hydrophobic monomers or dimethacrylate oligomers or unfilled resins, and they usually contain basically three things: bis GMA or UDMA monomer. Bis GMA is basically bisphenol, glycerol methacrylate, and UDMA is urethane dimethacrylate. These are monomers usually used in dentistry, and they may be activated by light if it's a one component or a single component system. Like in the picture you can see there is a single paste, so this is activated by light. Or if they're chemically activated, they are basically two components and they consist of two pastes which are mixed together. Then we have a diluent. A diluent, the function of a diluent is to decrease the viscosity and make it more easy to work with. And in that case, it is TECDMA, triethylene glycidyl dimethacrylate. And the third agent in the adhesive resin is a wetting agent. A wetting agent basically improves the flow properties, and in this case, it is HEMA. So these are the three components of an adhesive resin. We will be discussing the adhesive resins in detail later. Now let's move on to adhesion of enamel and dentine. We will look at it separately. Enamel adhesion was basically proposed by a dentist Bonocore in 1955, and he introduced the acid etch technique for adhesion of resin to the tooth. As discussed earlier in the previous slides, etching, basically we use acids to etch the enamel for sealing the pits and fissures, for enlarging and opening up the enamel tubules, for increased surface area to ultimately get better adhesion. Acid etching transforms the smooth enamel into an irregular surface and increases its surface free energy, which as you all know will ultimately improve the adhesion. As you can see from two pictures, these are SEM images. One is of the smooth regular enamel, of normal enamel on the left, and the second picture is of enamel after it has been etched. As you can see, the enamel tubules have opened up and it basically forms an irregular and rough surface. So this is the effect of acid etching on enamel. Modes of adhesion of enamel and dentine. There are basically four parts: the wetting, then the chemical bonding, then the micromechanical and macromechanical interlocking, and finally interpenetration. So these are the four steps or modes of adhesion of enamel and dentine. We will look at them separately. So firstly, wetting. As you all know, this means the intimate contact of adhesive with the adherent to fill the microscopic and submicroscopic irregularities. In simple words, it's basically the ability to flow intimately over a surface. Enamel and dentine are hydrated, hydrophilic, and permeable to water, so they require a hydrophilic, hydrolytically stable adhesive for wetting. And that is why we apply etchants to basically facilitate this mechanism. Then let's come to the chemical bonding. So when we are using adhesives have a chemical affinity for the adherent surface. Bonding to enamel and dentine is present in various systems consisting of coupling agents or cements containing polyacid. For example, the glass ionomer cements, which we will be discussing in the topic of cements, they undergo chemical bonding as they have affinity for both enamel and dentine, and they can bond directly to the enamel and dentine. The next important step is the micromechanical interlocking or enamel bonding. This is the basis of the bonding of composite and tooth. As I mentioned that in composites, the bonding takes place by micromechanical bonding. So because enamel has a smooth surface, it is impossible for it to for the dental composite to bond to it directly. So we have to make the surface rough, and we do that by carrying out acid etching. And this acid etching forms a rough surface which basically is more receptive to the adhesive and dental composites, and that is why micromechanical retention is required, achieved by etching. And finally, after etching, when we apply the adhesive, resin tags are formed which flow into the dentinal tubules that have been exposed by acid etching. And this is basically what micromechanical interlocking is, and this is the basis for for dental composite adhesion. Again, let's talk about acid etching. Penetration and locking of fluid bonding agents in these irregularities formed resin tags. So after we basically etched the enamel and we applied the bonding agent penetrated into the irregularities formed by the etching, and these formed resin tags. And that made a bond between composite and tooth structure. Now, when we are talking about acid etching, an important fact is the fact that 37% phosphoric acid for 15 to 30 seconds is used as an etchant. We discussed there are various etchants and conditioners available, but we use 37% phosphoric acid, and that too for 15 to 30 seconds. And when we do that, we achieve an etched enamel surface which looks like this image under the microscope. and they are basically microscopic irregularities or roughness. We'll also look at the steps or technique of acid etching. It is very important, and in your practical sessions, you will also get a demonstration of that. So there are basically 5 to 6 different types of acid etching patterns. I'm sure you must have done this in your first year BDS in oral biology. So, but the three, we'll just go briefly over the three types. Type 1 is the preferential dissolution of the prism pores, resulting in a honeycomb-like appearance. Type 2 is preferential dissolution of prism peripheries. So, this is the peripheries we're talking about, giving a cobblestone-like appearance. And type 3 is a mixture of type 1 and 2. So, this is what, how it will appear microscopically. Type 1, type 2, type 3. The effects of etching. It removes firstly okay, so if someone asks you what are the effects of etching of enamel, so firstly the smear layer is removed which was associated with cavity preparation. When you did the cavity preparation and instrumentation, the smear layer was formed obviously. So what etching does, it removes the smear layer, it differentially dissolves the enamel crystals in each prism, and ultimately increases the surface area for maximum penetration of adhesive and formation of micro tags or resin tags. So these are the effects of enamel etching. And if someone asks you why etch, so these are three reasons that why we etch enamel technique. So what is the mechanism of action? Irregular enamel surface due to dissolution of hydroxyapatite crystals. Obviously, the enamel is getting irregular and roughened. So the basically hydroxyapatite, which you know is the main component of enamel, dissolves, and it this what happens is that when it starts dissolving, the enamel tubules open up, there is an increase in the surface area, and this facilitates the penetration of bonding agent into dentin, forming resin tags. As you can appreciate from this picture, that these are the enamel prisms and etched enamel surface with micro irregularities, and this resin adhesive flows with into these tubules and irregularities, and this is called a resin tag, which is basically the flow of the adhesive into the opened enamel tubules into the irregularities. This is called the resin tags, and this is the concept of micromechanical retention. So it is a kind of mechanical retention because it's not chemically bonding, it's going inside, the resin is going inside the irregularities and getting interlocked. But and it's because they are microscopic in nature, it is known as micromechanical retention, and this kind of retention or bonding is present in composites. So by this retention or adhesion we achieve a good composite fit. So this picture shows the bonding of resin to enamel, which is, as I mentioned, micromechanical in nature. And the resin tags get interlocked with enamel tags or surface irregularities, which are created by the acid etching. So this is basically the whole crux of the mechanism of micromechanical bonding. So let's talk about bonding to tooth enamel. So basically chemical bonding, we have different bonding agents, and then like I mentioned in glass ionomer cements, they can bond directly by forming a chemical bond to the hydroxyapatite in the enamel, and they don't require etching or any other kind of bonding agent. Just apply them directly and they can make a chemical bond. Then the micromechanical retention, which is present in composites, that can only occur by acid etching. Let's look at the advantages or benefits of acid etching. Again, creating surface micro irregularities, removes the surface debris and stains, smear layer, increases the bonding surface area, increases the surface free energy, which you know will definitely facilitate bonding and increase the wetting and make the surface of the adherent more receptive to the adhesive. Types of acids use 30 to 50% phosphoric acid, but we go with 37% phosphoric acid, 10% malic acid, 2.5% nitric acid, and 18% hydrochloric acid. So these are the different etchant or acids that can be used, but we are using 37% phosphoric acid, which may be in the form of a liquid or gel. So what are the effects of acid etching on the enamel and dentine? Enamel, it causes selective demineralization. Again, depends if it's demineralizing the peripheries or the prisms or a combination of both. It increases surface area, increases life of composite because obviously uh, the, 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 the success of the composite depends on the etching. If you have done a good satisfactory etching, then obviously the bonding of the composite will be better. It will be retained, it will be durable. Decreases marginal staining, decreases secondary caries, decreases post-operative sensitivity. Again, these three factors are related to the fact that your composite filling was successful. Permits efficient wetting by hydrophobic resin and tag formation. Now, what does it do to the dentine? It demineralizes the dentine, opens the dentinal tubules, exposes collagen, and conditions the dentine for better wetting of the primer. It helps the resin tags to be formed, and ultimately, it in the end, it just facilitates and improves the. Now, the important part, the clinical basically aspect, the steps of acid etching. How do you carry out acid etching? This is very important and often asked in your UQs. You should give the proper steps, the proper details. So the first step is obviously you will isolate the tooth with a rubber dam or cotton gauze. It's very important that, as we mentioned in the earlier slides, that there should be no saliva or moisture contamination. There should be excellent isolation and moisture control. You should have a dry feel, which you can achieve with a rubber dam or cotton gauze. It is then properly dried with dry air. As you can see, this is the prepared cavity where we want to place the composite filling. So the first step we will do is the acid etching, and we have isolated it with a rubber band, with a rubber dam, and we place cotton gauze. Then we dry it with air. Next, we apply 37% phosphoric acid as etchant and leave it for about 30 to 60 seconds. So this blue gel is the etchant gel, which is 37% phosphoric acid. Now the newer of etchants, we don't require to leave them on for 1 minute. They work in between 15 to 25 to 30 seconds. So that is enough. So we leave it there. Then we wash the tooth with water for 15 to 30 seconds. So all of this acid is washed off. Then we dry the tooth again for 15 seconds until the enamel appears frosted or chalky. As you can appreciate from the third picture, the after acid etching, after application of this blue gel, which is 37% phosphoric acid, we wash it for 15 to 30 seconds, and then when we dry it, you will notice that the enamel appears frosted or chalky because the enamel has been demineralized, or the dissolution has taken place, and the enamel tubules have opened up, and there are microscopic irregularities present on the enamel. So then the bonding agent is applied onto the etched enamel. The next step is we apply the bonding agent, and this bonding agent will flow into the irregularities or the micro tags and form resin tags. So whenever you're asked to write the steps of acid etching, remember you have to write them in detail with the proper emphasis on the timing, that how many seconds or minutes you are applying the etchant, for how long are you washing it, and for how long are you drying it, and ultimately how will your enamel appear. So where are the applications of acid etching? This has made possible many innovative dental procedures like most important of all, resin composite based restoration. Composite fillings are only possible due to the acid etching. Porcelain laminate veneers, where we give porcelain veneers or laminates, that is also done after etching is done, and then only are they placed. Bonded orthodontic brackets, as you can see from the last picture, is basically of a orthodontic bracket, or what are known as braces. These are also bonded on the tooth, but after acid etching and application of bonding agent. And then fissure sealants, which I'm sure you must have or will ultimately study in community dentistry. This is a preventive method by which the pits and fissures of teeth are sealed to, and this is a basically preventive method. So this is also done after application of acid. So now, after talking about enamel adhesion, let's move on to dentine adhesion. Dentine adhesion primarily relies on, after basically acid etching and the formation of irregularities, and surface roughness, the penetration of the adhesive monomers into the filigree of collagen fibers that have been left exposed by acid etching. So basically the formation of resin or dentine tags is the concept of dentine adhesion. There are two steps of dentine bonding: conditioning and priming. Dentine conditioning, also known as etching, is basically same as acid etching. So it's the etching of dentine surface with acids or calcium chelators. When an acid is applied to it, dissolution of hydroxyapatite within the intertubular dentine and outer surface of the peritubular dentine occurs. The smear layer gets removed and the collagen fibers are exposed. So this basically is helpful because when the collagen fibers are exposed, the surface area increases and enhances the bonding and formation of resin tags. Materials used for dentine etching are 37% phosphoric acids, just like enamel etching. Nitric acid, citric acid may also be used along with EDTA, which is basically a chelator. So, what is conditioning? Conditioning of dentine can be defined as the alteration of the dentine surface, including the smear layer, and the objective is to basically produce a substrate or surface that is capable of micromechanical retention and possibly chemical bonding to the dentine adhesive. And how can conditioning be achieved? By two ways: by either acid conditioners or using chelators. Conditioners are similar to the enamel etchants, and they are basically acids like phosphoric acid, malic acid, citric acid, nitric acid, or oxalic acids and hydrochloric acids. And they also carry out the dissolution of the basically within the dentine. They cause opening up of the collagen fibers and the dissolution, so that basically the surface area is increased. Chelators, on the other hand, they remove the smear layer and do not cause any kind of decalcification or dissolution. And an example of a chelator, a calcium chelator, is EDTA. And as a result, increased bond strength is achieved. So these are the two techniques of conditioning the dentine. Now, the next is the priming. The priming is the process of applying primers to the etched or the conditioned dentine to improve the diffusion of the adhesive resin into the moist and demineralized dentine. The primer solution is a mixture of monomers with hydrophilic and hydrophobic components dissolved in organic solvent. And the priming agents are HEMA and META. So these are also monomers and they basically carry out the priming. And what do? Is they basically make they have the hydrophilic and the hydrophobic end, and they help in better adhesion. Now, what are the coupling agents for chemical bonding? So, they are represented by an MRX molecule. Again, we're talking about the primer. As we said, it is a bifunctional molecule with one end which is hydrophilic and one end which is hydrophobic. So, the MRX molecule represents this bifunctional molecule. The M stands for the methacrylate group that bonds with the composite, and the R is the spacer group in between. The X is the molecule on the opposite sides of the M, and this is the functional group which is targeted for adhesion with tooth tissue to chelate with calcium in enamel or dentine. So the M basically bonds to the methacrylate group, and the X bonds to the tooth structure and chelates with the calcium which is present in the enamel or dentine. And this is called the MRX molecule, which is basically the primer. Now, a very critical step in the dentine bonding is the formation of the hybrid layer. This hybrid layer is basically the zone where the adhesive resin of the dentine bonding agent micromechanically interlocks within the intertubular dentine and surrounding collagen fibers that have been exposed due to the etching. So the hybrid layer is formed in the following manner. Firstly, when we carry out the etching, this removes the smear layer and exposes the collagen fibers. And it also removes the hydroxyapatite within the intertubular dentine. So after this, as soon as the bonding agent flows within these irregularities and forms the resin tags, this is basically the formation of the hybrid layer. So as you can see from this picture, there are three layers. The top one is the composite layer, then is the adhesive, and then the hybrid layer. So the hybrid layer is basically the layer between the adhesive the etched enamel and the resin tags. So it's a tri-layer tags. The primer penetrates into the collagen network. Adhesive resin along with the primer forms resin tags, and this is called the hybrid layer, also called the resin dentine interpenetration or interdiffusion zone. So the last and the most important step, which is the interpenetration zone, is basically the step where hybrid layer is formed. As you can see from this diagram, you have the resin composite on top, the adhesive or bonding agent in the middle, and then this black layer is the hybrid layer, which is between the dentine, the bonding agent, and the etched enamel. So what are dentine bonding agents? Dentine bonding agents are the di or multifunctional organic molecules that contain reactive groups which interact with dentine and the monomer of the restorative resins. So basically their function is to interact and bond from one end with the dentine and from one end with the composite. Now, dentine bonding agents have been classified according to generations. These are very important, and this is basically a kind of timeline that follows from the first generation to the sixth, seventh, and eighth generation. So let's look at the dentine bonding agents, the classification. The first generation dentine bonding agents or adhesives consisted of NPG GMA monomer added that chelated with the calcium in the tooth surface. Now, the shortcomings were that it had very low bond strength and it was unstable in solution. Now, the given information is more than enough for you. You should just know what the first generation consisted of and what the disadvantages were. If you are ever asked to classify them, this is more than enough. This is all you need to write. Then the second generation dental adhesives were a halo of phosphate ester of unfilled resin such as bis GMA or HEMA. Mechanism of action, no need to really go into detail, but it was basically because of the interaction between negative phosphate in the resin and positive calcium in the smear layer. Shortcomings were that the bond strength again was very low and it did not wet the dentine well or penetrate the smear layer. So that's why both of these generations were, you can say, disregarded and they weren't basically used anymore because the results were not successful. Then the third generation dental adhesives. Now, in this, the principle was to modify and not remove the smear layer. In the previous two, we were trying to remove the smear layer. Now, the aim of the third generation dental adhesive was to modify the smear layer and condition it to allow penetration of molecule monomers like HEMA, BIS-GMA, or NPG-GMA. So what we did, we modified the smear layer to make it more receptive, conditioned it to make so that penetration of adhesives can take place. However, the shortcomings were that the clinical outcomes were not up to the mark, so they were also discontinued. Then came the fourth generation dental adhesives. Now, this is where the hybrid layer formation took place. This was called total etch and moist dentine bonding. So basically, enamel and dentine were etched by application of a primer, which was a hydrophilic monomer and solvent and adhesive. For example, methacrylate phosphates. Shortcoming was that it was very lengthy and multi-step procedures. First, we etched the enamel, then the dentine, then we applied the primer, then we applied the adhesive, and then we applied the composite. And this increased the chair side time. So this was one of the these were the shortcomings of the fourth generation or the hybrid layer formation adhesives. Then came the fifth generation dental adhesives. So that is basically a one bottle system. The primer adhesive resin combined after the acid etching. So we are using the fifth generation in clinics nowadays. A lot of people have gone to the sixth and seventh as well, but the fifth generation is what is commonly being used, and this contains one bottle which has the primer and the adhesive together, which is applied after acid etching. So you simply first acid etch the tooth, and then after etching is achieved, we apply the primer and adhesive, which are basically in one single bottle. So you don't have to apply the primer separately and the adhesive separately like the fourth generation. The primer and adhesive are combined. So after etching, we apply that, and after that, we apply the composite. So they're just three steps. So this is the basically dental the bonding agent that we are using nowadays. Now the sixth and seventh were even more simplified. Came in two types: self-etched single bond and all etch. Now the self-etched single bond contained everything in one bottle: the etchant and the primer and the adhesive. So this was all in one bottle. It was just to two step. You apply the single bottle, you wash it, you cure it, and you get your and it is ready to receive the composite filling. Now all etch, again, etchant, primer, adhesive combined, no rinse etch. In this you don't have to rinse it, you don't have to etch it. So again, both these sixth and seventh generation, the advantage was that there are less steps. So the self etch single bond, you etch first and then you apply the primer and adhesive, and in all etch, all of the three components are combined. As you can see, this reduced the steps, the chair side, it made it simpler. So this table basically gives a better idea. So 1960, the first enamel etch only, they tried to just use composite by first etching the enamel only. They did not apply any adhesive, but that resulted in poor adhesion. Then they improved the enamel, the etchant, but there was improved adhesion, but however not satisfactory. And then with multi-step, total multi three-step, then two-step, and then finally it was reduced after 2011 into total self or selective etch, which was one or two steps only. It was also known as all etch. So this is a timeline of the dental agents. If you look at this pictorial representation, it will be much clearer. So the fourth generation, you have a primer, an adhesive, and an etchant. There are basically two bottles and one etchant. In the fifth generation, which as I mentioned is what we are using nowadays, we have one bottle which contains the primer and adhesive in it and an etchant separately. Sixth generation, etcher and primer we may be together and the adhesive is separate. And then the seventh or the latest generation has everything, all of these three components in one bottle. So let's look at the bonding agents from this perspective. The three steps were etchant, primer, bond. Two steps were self-etching primer, and the bonding was separate. And the one step or the seventh generation were all in one adhesives, and these were called self-etching systems. And where we require to do three different steps, we called it the acid etching system. So, what are the important clinical aspects? First of all, proper isolation by using rubber dams. Saliva contamination can block mechanical bonding. We have to carry out pulp protection, especially if it's a deep cavity, and we do that by applying calcium hydroxide. This is a cement we will be studying in detail later. Acid etching of enamel and dentin is carried out by 37% phosphoric acid for 15 seconds to 30 seconds, and then we wash and dry it. Dentin surface must be kept moist. If dentin is over dried, it can result in collapse of the exposed collagen fibers. Careful application and curing of bonding agent, and placing the resin immediately. So these are all the clinical considerations which we'll be studying in detail later on. And these are also the critical steps in bonding. Now, what are the indications for clinical applications? So, all the direct composite resin restorations, both interior and posterior, for bonding indirect composite resin inlays, onlays, and veneers, for bonding indirect ceramic veneers, inlays, and onlays, and for the bonded amalgam restorations, management of dentin hypersensitivity, and luting, post, and core restorations. These are all the clinical procedures in which we require bonding as well as acid etching. And we won't go into the detail of these techniques at this stage. You just have to know that where the bonding and acid etching is applicable in which procedures. So that brings us to the end of adhesion and bonding agents. Our next lecture will be of dental composites, and I hope it's clear. If you have any questions, please do let me know, and thank you for listening.